Welcome to Part 1 of the New York State Opioid Prescriber Training Program. I'm Ed Bednarchuk, Chair of the Department of Pharmacy Practice at the University at Buffalo. This module will cover 4 of the mandated areas of training required by New York State. So why are these areas required? What is the purpose? What's the motivation that we've got for addressing these concerns? In this widely publicized data set from the CDC, we're immediately struck by the sharp increase in opioid-related deaths, even as deaths from prescribed opiates has begun to plateau. When we look at data from New York State, it reflects the national trends, both in increases in heroin-related deaths and in increases in prescription opioid-related deaths. To combat these trends, New York State has implemented a series of steps intended to mitigate the problem. These include the Internet System for Tracking Overprescribing, better known as iStop, the requirements for e-prescribing, as well as legislation requiring prescriber education. Now, the legislation that requires prescriber education has a fourfold intent. The first is to require CME on pain management by physicians and other healthcare providers. This legislation also mandates insurance coverage for needed inpatient treatment services. It limits opioid prescriptions from a 30-day supply to a 7-day supply. And then finally, it requires pharmacists to provide additional education and counseling to those receiving opioids. So what's the who, what, when of the mandated prescriber opioid training? All prescribers with DEA numbers and medical residents prescribing under a facility DEA number are expected to complete training. The what is that at least 3 contact hours of coursework or other training in pain management, palliative care, or addiction need to be completed. And this training must be completed by July 1st, 2017, and then upon license renewal. The curriculum for this course is that the training will include, but not be limited to, pain management, appropriate prescribing, management of acute pain, state and federal requirements for prescribing controlled substances, prevention, screening, and signs of addiction, response to abuse and addiction, palliative medicine, and end-of-life care. The overall objectives of this module are to describe the pathophysiology and general approaches for pain assessment in the ambulatory setting, to describe approaches for managing acute pain and how they would differ from approaches for managing chronic pain, to outline clinical guidelines for appropriate prescribing of opioid analgesics, and to list the federal and New York State requirements for prescribing controlled substances. As we move into our program, it's our hope that this material will add to your understanding of opiate prescribing and improve patient safety in the state of New York.
My name is Dr. Wagbury. I'm a board-certified interventional pain specialist. I've been in practice for 30-plus years, and in private practice with some academic affiliations. I'm both interventional and medical pain management. So the discussion will center around the appropriate management of acute pain, and we will touch also on chronic pain with regard to appropriately prescribing medications in a responsible fashion. We are going to initiate this slide presentation with a basic understanding of the pathophysiology and the approaches of assessments of pain in an ambulatory setting so that appropriate prescriptions, if required, can be selected. In order to understand the basic premise of the presentation, it's important to understand what pain is. And pain is, by definition, which is accepted worldwide, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, which is usually described in terms of such damage. The difference when it comes to differentiating acute pain is acute pain usually results from some sort of inciting event or from some sort of disease process, such as various organ system illnesses that may produce pain, which usually takes a patient to an ER or to the physician for further evaluation and management. Traumatic episodes can result in acute pain, and it's important to realize in the concept of acute pain, we expect acute pain to improve over time as either the healing process occurs or appropriate treatment is instituted. And pain itself in the acute form is a biologically important process, and it's actually a protection system that the body has developed in order to basically obviate further damage that has resulted from the process that created the acute pain. Chronic pain, on the other hand, usually exists far beyond the acute pain episode or the inciting event that resulted in acute pain, and also long after the processes that have been used, that the body initiates to create a healing process, have basically been initiated and have been concluded. So chronic pain persists beyond the expectation of whatever produced the acute pain. By typical definition, you will see variations anywhere between 3 to 6 months, and chronic pain typically affects the human being in many ways than just being a protective element that causes a complete alteration in the patient's quality of life and their ability to function on a day-to-day basis. So it's pain that persists beyond what you expect in terms of a time frame. If you look at pain processing, acute pain processing, there's an inciting event in the periphery that results in the fibers that transmit the pain impulses, particularly the C nociceptor fibers, to the dorsal horn of the spinal cord. They cross over through the first synaptic cleft over to the opposite side and then get transmitted to the brain by various pain pathways. Initially synapsing in the hypothalamic region or thalamic hypothalamic region, where then synaptic processes occur that then takes the impulses to the brain, which goes into basically 3 main areas of the brain: the frontal, the somatosensory cortex, and the locus coeruleus. And essentially the interpretations are made and impulses come back out that attempts to modulate the impulses that occur in the spinal cord in the first synapse. And that's basic processing. And so when you treat acute pain, or in fact even chronic pain, you can intervene in different segments of the processing pathway to try and minimize the impact at the processing in the brain. When you look at pain, it's important to categorize pain. This is developed from myself. Pain can be looked at from the point of view of how severe it is, the pathophysiology, the disease origin, and the temporal characteristics of the pain. When you look at severity, pain can be mild, moderate, and severe. Keep in mind that this is very subjective. It's the patient telling you, I have mild pain, moderate pain, or severe pain, and that's based on various tools that one can use to assess the level of pain. And so it is subjective, and you will see a movement away from this categorization simply because of the subjective nature of it. The pathophysiological breakdown is important in deciphering how you're going to initiate modalities appropriately for nociceptive, neuropathic, and mixed pain so that you can minimize the impact of that on the patient. Disease origin is important, cancer versus non-cancer, as cancer pain is uniquely different in terms of its approach, whereas non-cancer pain tends to be more streamlined and has the same approach to almost all elements of non-cancer pain, as long as it's defined by the pathophysiological origin. Temporal characteristics are important, and this is what we're here to discuss today. So you have the acute pain, which I've mentioned a little bit about, and we're going to talk more about it. And then you have the chronic pain, where it's outlived the protective elements that the body has initiated, and the patient has been left with a state of chronic pain, where you have either persistent chronic pain, which is pain that's there all the time. You have intermittent pain above and beyond the persistent pain, which is little flare-ups of the baseline pain. And then you have what's determined to be true breakthrough pain. And breakthrough pain is very specifically more seen in incident-related pain in someone who has chronic pain. I want to add in here that chronic pain, while I've mentioned the acute pain pathway, when one looks at chronic pain, this, based on our understanding today, is a complete alteration in spinal cord morphology and physiological function. There's actually alterations in cells within the spinal cord of the central nervous system that create abnormal connections and pathways that result in the chronic pain state. So the important thing to realize with chronic pain, even though the initial acute pain has resolved and there's healing in that area where the acute pain started, when you come into chronic pain, the pain is no longer originating in that particular area that initiated the acute pain. It is in fact originating from alterations in spinal cord function and anatomical organization. So when you have pain with different pain states, or at least pathophysiological processes, you have neuropathic pain and you have nociceptive pain. And then you have mixed pain. So patients can present with neuropathic pain that have components of nociceptive pain and vice versa. So some examples of neuropathic pain may include postherpetic neuralgia, trigeminal neuralgia, a painful diabetic neuropathy, post-surgical neuropathic pain from various surgical causes, traumatic neuropathic pain, and then you have central post-stroke pain syndrome, which is a neuropathic pain syndrome. On the other end of the spectrum, you look at nociceptive pain, which is your inflammatory pain processes, limb pain after a fracture, which is healed, joint pain in osteoarthritis, which can present with ongoing acute inflammation, post-operative visceral pain. Those are examples of nociceptive pain. And when you have the mixed pain pattern, low back pain with radiculopathy can be predominantly a mixed pain pattern. You can still have components of neuropathic pain with that. Likewise, cervical radiculopathy. Cancer pain is a mixed pain. Carpal tunnel syndrome is a mixed pain. So common descriptors of neuropathic pain are typically burning, tingling, electric-like sensation, hypersensitivity to touch or cold in the area where the pain appears to be originating. Whereas on nociceptive pain, the common descriptors are aching, sharp, throbbing. And when you look at mixed pain patterns, patients may report dull, stabbing, with components of both neuropathic and or nociceptive if those components are part of the mixed pain pattern. Clinicians' knowledge of pain management is somewhat restricted, basically because of lack of a knowledge base, failure to understand the mechanisms of pain and to target the appropriate mechanisms, failure to treat or at least to include adjuvant medications in the overall treatment protocol of the pain that you're treating, and the heavy use of short-acting opioids instead of long-acting opioids, or in fact vice versa, basically due to a lack of understanding of how these particular molecules may be used appropriately in the overall treatment of pain. Before one evaluates pain, one has to evaluate the patient as a whole. So a comprehensive evaluation is done, not just focusing on the pain. It requires a full history, a full evaluation of the inciting events or how the pain started, a full physical exam, and an evaluation of the laboratory and diagnostic elements that have brought the patient to your office. And if they don't exist, perhaps these need to be ordered before making a definitive assessment. You have to determine the underlying mechanism. What is causing this patient to have pain, and what, in your judgment, based on your evaluation of the patient, examination of the patient, and evaluation of the testing, is leading you to believe a particular mechanistic pathway. Pain has to be characterized when you take a history as what's the quality, the site, the severity, and we're going to talk further about that. The PQRS-TU mnemonic is a helpful tool to evaluate pain symptomatology. P representing precipitating and palliative elements that have precipitated the pain, and what things the patient has done in terms of medications or activity levels or other options to try and reduce that severity of the pain. The quality of the pain, how the patient describes it, the region, and does it radiate anywhere. The severity using pain scales. And I'm going to talk a little further about that because in terms of deciding what to use, severity doesn't appear to be that important. Timing, the onset, time of day, the pattern, the duration, what brings it on, what doesn't, it's important, and how the pain has affected the patient's quality of life in terms of functioning and essentially other elements of day-to-day functioning. Pain severity has to be evaluated on every visit, irrespective of what intervention you have initiated in the patient. So every visit should have an element that talks about the current pain compared to the previous visit, the worst pain in the last 7 days, the lowest pain in the last 7 days, and the average pain in the last 7 days. Useful bedside rating scales are available. You can look at the visual analog scale. You can look at the numeric analog or numeric rating scale. The Wong-Baker FACES pain rating scale is an option. The PQRS-TU is an option. And there's scales for special populations, and I'll refer you to the relevant references for that. This is an example of what's available. And I'm not going to belabor it and go into in depth, but they're available on the internet and you can incorporate that into your practice. We're going to go on in looking at approaches for managing acute pain and how they differ from managing chronic pain. So in acute pain, as we've mentioned, or as I've mentioned before, is a result of an injury or an illness that we expect it to be time limited, and it's a recent onset, that result. It's divided into two types, both somatic and visceral. Somatic would involve bone, joint, muscle. It's usually described as a constant pain with an ache, a gnawing, a throbbing, and it's usually well localized. Whereas visceral is coming from the visceral organ systems, poorly localized. It's a deep kind of pain. It's intermittent and cramping, and it can't be particularly localized to a particular area. It tends to be more diffuse. Acute pain, as I mentioned before, is a protective element, and all organisms in the hierarchy of living creatures are able to experience acute pain. Their presentation and expression varies, and I think we have the most sophisticated expression being human beings. Characteristic of acute pain, it's usually of short duration. Pain is expected to resolve within days to weeks as the body attempts to modulate what happens in the periphery wherever the pain was initiated. If the pain is present for more than 12 weeks, which is beyond 3 months, it should be considered to be harboring onto the chronic type of definition. Pain of varying intensities is noted with acute pain, and we expect it to subside with healing, as I mentioned. Nervous system is usually intact. There's no significant injury most of the time. The reasons for the pain is usually identifiable. It's trauma, it's surgery, it's a medical condition, and it is a pathophysiological process. It usually responds very well to non-pharmacologic treatments and non-opioid analgesics. Psychological problems such as depression, if they exist, are usually pre-existing and are not usually seen as a result of acute pain. If they are pre-existing, it could have an influence on the ability to recover adequately from the acute pain episode. If depression is associated with acute pain, and if the acute pain is appropriately treated, the depression is usually self-resolving. Acute pain management. Opioids are not the first line of therapy for acute pain. And that should be taken with a certain amount of consideration based on how severe the pain is in the patient and how limited or how positive your exam is when you evaluate these patients in acute pain. Opioids should be reserved for acute pain, as the second bullet says, where alternative treatments are ineffective or contraindicated, or where the acute pain results in very severe restriction of ability to function on a day-to-day basis. So the first bullet doesn't say you should never write an opioid for acute pain. There is a role for opioids in acute pain when there's an indication based on the second bullet where it shows significant restrictions in ability to function on a day-to-day basis. So initial treatments for general acute pain without that provisor, as mentioned in the second bullet, should be non-opioid analgesics in combination with non-pharmacologic therapies or modalities. Opioids, we have to understand, if we do select them, their mechanism of action is on the opioid receptors, and there are basically 3 main opioid receptors in the human body, with a 4th receptor that is now being determined, or our understanding is that it's really not an opioid receptor. So the big ones are the mu, the kappa, and the delta, with the mu providing the supraspinal analgesia, respiratory depression, euphoria, sedation, and the opioid-induced constipation as a result of reduced GI motility. That one is most susceptible to physical dependence with chronic long-term opioid use in an uncontrolled fashion. The kappa receptor, which is spinal analgesia, sedation, dyspnea, dependency, dysphoria, and respiratory depression. That's where your dangers are with opioids. And the delta, which is responsible for psychomimetic and dysphoric effects. Pure opioid agonists. This is an example. It's not a mutually exclusive list, and there are other elements that could be added to that list. They do have a high binding affinity at the mu opioid receptor. There is no dosing ceiling effect, and the analgesia is limited by basically side effect profile. Typically if you increase the dose, you will have some increase in analgesia. However, that's not totally true when you're on higher doses of these medications, as there's more of an element of opioid hyperalgesia or tolerance that develops with these medications. Other opioids that can be considered, tramadol and tapentadol. These are weak opioid agonists at the mu opioid receptor, They may be used in neuropathic pain syndromes simply because both these medications have dual effects when they are taken, not only opioid related, but also either serotonin or norepinephrine effects, as mentioned there. Short-acting opioids. This slide is a busy slide, and the important elements to consider here is no matter what opioid you prescribe, keep in mind that opioid metabolites themselves can be detrimental in terms of their side effect profile. So if you look at morphine, the morphine 6G metabolite may accumulate in renal impairment and result in toxicity. If you look at hydromorphone, you require dose adjustments in renal and hepatic impairment. If you look at tramadol, you need to start low and titrate slowly, and it may produce the serotonin syndrome, and that's one of the boxed warnings in that particular drug. So it's important to realize this and when you consider which opioid molecule you're going to prescribe for the patient. When looking at opioids, you may start with one particular opioid molecule, but may want to switch to another, and this is where an equianalgesic dosing conversion table is available to assist you in making those conversions. Of note, more importantly, is when the conversion is made, the recommendation is you start 20% lower than the dose you've calculated the conversion to be. And that's just safe practice. The concept of morphine milliequivalence or milligram milliequivalence is important. Based on current guidelines, we all know that using doses greater than 50 MME per day increases the risk of overdose by at least 2 times. So the key is to keep doses lower than 50, preferably below 20 MME per day. If you do need to go above 50 MME per day, make sure that these patients are monitored frequently, that there is a discussion of opioid reduction in terms of total daily doses, perhaps tapering. Consider the addition of a reversal agent such as naloxone, naltrexone products that are available, and avoid going above the 90 MME per day. And this is in the CDC guidance data. Calculation of MME, 2 excellent tools available, and you can simply go to the site to download those tools. Side effects are important when you prescribe an opioid. We mentioned the GI side effects, constipation and nausea. The CNS side effects, which are actually more important and results in overdose and death possibly. Drowsiness, tiredness, dizziness, sedation, confusion, hyperalgesia. Then you have pruritus, which is histamine-related or mediated, dry mouth, sweating, and sexual dysfunction. Sexual dysfunction, I might add, is the one that's least looked into in patients taking long-dose opioids. And why that's important? Because low gonadotrophic hormones or gonadal hormones actually increase pain perceptions. So you might find a patient who's been on an opioid for a long term, who has severe gonadal hormone suppression and gonadotrophic suppression, actually coming to you saying that the pain is worse. And if one doesn't really evaluate those levels and treat them, you may be missing the boat in terms of why the patient's complaining of increased pain. It's not because the opioid's not working, it's simply because they're having significant gonadal hormone suppression. Tips for managing the side effects. Of course, you manage nausea and constipation. You may or may not need to use antiemetics. It's important to realize that when you initiate someone on an opioid, nausea may be a reasonable side effect that's commonly reported in patients. And what we've seen is that as long as the patient's not throwing up profusely, that nausea usually resolves or may settle down by just changing when the medication is taken and perhaps suggesting the patient take it with a full stomach, perhaps take it at night, and encourage the patient to continue to take it. We may see that settling down. So just a patient complaining of nausea when you initiate an opioid doesn't necessarily require you to switch to a different molecule. Likewise with constipation, diet modification, over-the-counter medications that can be used for constipation may be quite successful. If the constipation becomes a problem, you may need to go to the stronger agents that are available. Adverse events, as I mentioned here, may respond spontaneously with continued administration, and we mentioned here except constipation. Slow titration is always the rule. Start low and titrate slowly. 1, it minimizes the side effects. 2, it allows you to obtain the lowest possible dose that gives you the maximum possible benefit. Management of opioid-induced constipation. We mentioned the over-the-counter Docosate, sodium docosate is little value alone. It needs to be combined with perhaps diet modification. We have the stimulants such as senna, which is the mainstay of therapy. The osmotic sort of constipation drugs such as lactulose, sorbitol, glycol, and glycerine definitely are additives to the stimulants. They should not be used alone. The saline elements, magnesium citrate, cathartics, they relieve and then adjust the bowel motions. Those certainly can be used. Then you have the peripherally acting opioid receptor agonists, the so-called PEMORA agents, naloxegol and methyl naltrexone. They are designed in such a way that the molecule is too large to cross the blood-brain barrier and essentially reverses the effects of the opioid at the enterocytic opioid receptors. And then you have the lubricants such as mineral oil, which can be used to assist in those very solid dry stools in transiting through the GI tract or the colon. So acute pain management and when do you use an opioid? First-line treatment, as I've mentioned, is non-pharmacologic with the introduction of non-opioid analgesics, such as acetaminophen and non-steroidal anti-inflammatory drugs. With Juven therapies, you prescribe the lowest safe effective dose of an immediate opioid if you need, once they fail the first-line treatments. Combine those non-pharmacologic treatments and non-opioid treatments along with the opioid if you initiate it. That will result in a lower dose of opioid being used, and select your elements appropriately to improve function. Your gauge as to how well the patient's doing with your interventions is based on an examination, a full evaluation of the patient in relation to improvement of quality of life and functional improvement. A patient that sits in bed and says, I have a pain that's 10 out of 10, and you give them an opioid and you see them on follow-up and you ask them, what are you able to do? And the response is, I sit up in bed and I'm able to eat food in bed, doesn't constitute continuation of opioid, because that's really not an improvement in overall function. And that's just an example that I use. So opioids in acute pain scenario should not be prescribed for longer than necessary. And that's based on your understanding of the healing process, your reevaluation of the patient after you've initiated opioids, and the current teaching is not to prescribe opioids longer than 7 days. And you have to justify continuation of the opioid based on your reevaluation of the patient. Patients prescribed opioids for acute pain are at a higher risk of using opioids long-term if you do not appropriately monitor and evaluate the patients for efficacy to determine when to discontinue the opioids. It is commonly assumed that anywhere between 3 to 7 days is sufficient if you are going to use an opioid in the acute pain scenario. This necessitates your reevaluation of the patient to determine if further opioid prescribing for acute pain is warranted. I've stressed that reevaluation is extremely important when you are determining if a patient should continue to remain on opioids. Our understanding, based on what I've mentioned before, is 3 to 7 days is what we expect in most instances of acute pain. Hence, if you have provided opioids for 3 to 7 days, you need to reevaluate the patient in your office to determine if continuation of an opioid is warranted. Extended release formulations should not be prescribed because in most instances of acute pain, 3 to 7 days is what is expected. However, if you expect this pain to last longer than that, a few weeks, depending on the patient's response to your initial opioid, you may want to consider an extended opioid in order to limit the number of units of the short-acting opioid that you've prescribed that the patient is allowed to use. However, one should exercise extreme caution when initiating an extended-release opioid. By and large, it's not the rule of thumb to use an extended-release opioid as the first opioid when treating acute pain. The patient has to be educated on the potential risks and side effects of the medication you are prescribing. Also, more importantly, they should be educated on their responsibilities when using an opioid. Such responsibilities may include keeping their medications locked, keeping the medications away from pets and children, and using the medications in a responsible fashion as prescribed. And that any changes to how the medications are used has to come from the prescriber of that medication and not anyone else. You should also avoid prescribing opioids in combination with other CNS depressants, as this increases the risks of potential respiratory depression and excessive sedation, which can result in respiratory depression and potential death. Such other medications include benzodiazepine, sedative hypnotics, and skeletal muscle relaxants. If a patient is on an opioid for acute pain and there is no improvement in the pain as reported by the patient, and more importantly, no improvement in function, which the patient reports, which you can justify based on your examination or verify based on your examination, and there's no improvement in quality of life, the continuation of that opioid is deemed inappropriate. And consideration should be made to discontinue or wean the patient off the opioid, depending on the dose that the patient has been prescribed. So the pharmacologic treatment options for acute pain include acetaminophen, the NSAIDs, such as ibuprofen and naproxen, the COX-2 inhibitors, which can be used as an option instead of NSAIDs, the full opioid agonists, such as the combinations, which may include opioids with the acetaminophen products and opioids with NSAID products, which can be started initially. And if they're insufficient to control, then you can go on to the stronger opioids. A drug such as tramadol may be considered initially as well as a second line, or in fact even in conjunction with an NSAID for the pain process that the patient has. In chronic non-cancer pain, we look at neuropathic pain. Keep in mind, neuropathic pain in most instances tends to be relatively opioid resistant. So hence, selecting an opioid as the first-line treatment is probably not a good option. So first-line treatment options for neuropathic pain include the calcium channel modulators, which are the alpha-2 delta ligands, such as pregabalin and gabapentin, the serotonin norepinephrine reuptake inhibitors, and the tricyclic antidepressants. In that pool, one could also add Tylenol, one could also add a muscle relaxant into that pool. A second-line treatment option may include topical agents, such as lidocaine, capsaicin, which are available and are labeled as topical agents that can be used. In the classification of musculoskeletal pain, by definition, this is pain caused by a lesion or a disease of the musculoskeletal system. And that system includes muscles, ligaments, tendons, cartilaginous structures, and joints. And can be seen in different anatomical regions, such as neck, shoulders, and into the lower extremities. By description, and when you evaluate the patient, you will actually feel, and the patient will tell you that their muscles are tender in various sites, and the patient may have trigger points or tender points, depending on which elements are painful at that time. Causation is usually by an injury, such as repetitive motion, an occupational injury, perhaps a fracture, a dislocation or a compression by a tumor, a cyst, or a bony structure. First-line pharmacological treatment is Tylenol, once again, with NSAIDs and topical agents, and I would add into that continue to exercise, continue to use the area that's painful, and do exercises so you promote mobility and stretching of that area. You have inflammatory pain, which by definition is an inflammatory process of some nature, such as an infection. Autoimmune diseases can give you inflammatory pain. With this is associated the infiltration of immune cells and relevant tissue damage that can sometimes make inflammatory pain worse. It's progressive pain, so that can result in worsening. That is usually sharp or lancinating, and it may have incident increase based on what you're doing, movement, certain activity that can cause the pain to get worse. The pain site will demonstrate inflammation. It can be tender, hot and red, with swelling at the site, and there may be a history of injury or sometimes no injury, but just an inflammatory process going on. With specific inflammatory pain processes such as rheumatoid arthritis and various other arthritis or inflammatory conditions, you would have to refer to the protocols related to that particular condition. Again, first-line treatment options do include NSAIDs, glucocorticoids, topical agents can be used for that. Treatment options that are non-pharmacological are very important because these have to be initiated along with first-line modalities, as I've mentioned in the previous slides. Behavioral therapy is important to teach the patient how to cope with the pain. Cognitive therapy is an element of behavioral therapy. Coping skills, how to deal with pain from a mental point of view, how to use mind over matter processes such as biofeedback, perhaps hypnotherapy, and those elements should be initiated if indicated. Integrative therapy such as acupuncture and massage therapy helps the patient to recruit other modalities and pathways to modulate the pain process and the experience of pain. Physical therapy is another important element that should be initiated as a non-pharmacologic first-line therapy to manage the patient's pain. Multimodal analgesic approaches are very important. If you decide to select medication as a method to treat the patient, it's important that there are different elements in the pain pathway that could be attacked using an oral medication of some nature, such as an SNRI, such as topical agents such as lidocaine, which uses a non-opioid pathway to modulate pain. This introduction of these modalities along with opioids results in you using the lowest possible opioid dose, thereby minimizing adverse events related to the individual drugs that you use. Most patients will benefit from a multimodal approach, and it should always be considered as a rule of thumb when managing a non-cancer pain patient. Multimodal approach also has opioid-sparing effects, allowing you to use the lowest possible dose. The current consensus guidelines supports a multimodal approach in treating the patient with pain, providing them adequate analgesia. Reassessment is extremely important. Irrespective of which mode you initiate, you need to evaluate efficacy of that mode in order to determine if you need to adjust the mode, add a different mode, or add something new like an opioid or a modification of the medications that the patient's currently on. This reassessment should be done at least 2 to 4 weeks after initially initiating your modality. When you initiate short-acting opioids, the pain has to be severe enough to require an opioid analgesic. This is important because I've mentioned pain that's moderate to severe. That's based on a subjective report of the patient, and the tools you use are the patient's subjective reporting. So the patient telling you they have pain 10 out of 10, which to that patient is pain 10 out of 10, and then likewise translating that into the numeric scale of 10, doesn't mean that the patient has severe pain that would initiate an opioid right away. The onus is on you to basically determine, yes, the patient's reporting 10 out of 10, but my exam does not substantiate that level of reporting. If it doesn't, then that is not pain severe enough to warrant an opioid. And you have to determine, based on your evaluation, that what the patient reports does translate into an examination that leads you to believe that this patient requires an opioid analgesic. To that extent, a thorough, full evaluation of the patient is extremely important, and we have stressed that before. So you have to evaluate how the patient's done with non-pharmacologic actions or interventions and non-opioid therapies. And these should be evaluated to determine if indeed a short trial of short-acting opioids is appropriate. You should educate the patient that even though you are providing them an SAO, that your aim is not to give them zero pain. Your aim is to improve their function and their quality of life, and they may still experience some pain. Studies suggest that if pain improvement does occur with an opioid, it usually averages about 2 to 3 points on that visual numeric scale. In fact, if you look where that data comes from, when FDA does studies on opioid molecules for pain, they look at an improvement of 30%, and 30% on a 10-point scale is 3 points. Patients should be evaluated for risk and should be assessed for risk. So for all patients who come in pain, there should be a risk stratification that has to be done. Whether you decide to give them an opioid or not, that risk stratification should be in your notes, which will guide you in terms of the interventions, and both pharmacologic and non-pharmacologic, that you're going to follow. For all patients, a risk assessment for potential opioid misuse should be done as well. Whether you initiate or not initiate, that should be as part of your medical record. There are many screening tools available to identify patients at risk for aberrant behaviors or substance use disorders. And based on the risk level, this allows you to prescribe and monitor the patients in an appropriate fashion. There are mitigation strategies available to prevent abuse and addiction. These strategies help prescribing or prescribers to monitor adherence to the medication you're prescribing and to minimize the possibility of diversion, misuse, and abuse. So a patient opioid or treatment agreement with regard to pain should be the first part of the paperwork the patient fills in when they come to your office, not something they fill in after the fact. They should have an agreement that suggests, or wording that suggests, that they are in full agreement and will follow your treatment plan, as well as they will follow your medication responsibility education that you've provided to them. Routine or random urine testing should be part of every office protocol when dealing with patients in pain. One may argue, why do urine testing if you're not going to prescribe an opioid? You do a urine testing to pick up anything abnormal in the urine that needs to be addressed that might be contributing to the overall pain behavior. To this extent, the iStop law, which involves a prescription monitoring database, has been created and is a very valuable tool for you to be able to get information about what the patient has been on prior to seeing you in the office. Random pill counts, if a patient is given scripts from your office, should be implemented in your office, and this should truly be random, where you bring the patient in, you count the number of units they have, and verify that that is appropriate based on your dosing regimen. The COM-17, which is the current opioid misuse measure, which consists of 17 questions, is an extremely useful tool that can place the patient in a risk category, high risk, low risk, or moderate risk. And then routine patient assessments are extremely important based on what you're prescribing. And that routine assessment can be based on how often you wish to see the patient in the office. At any rate, a minimum of once a month is almost required before you can continue a patient on a prescription. There are some sites you can go to get some examples of opioid consents and agreements, and you can tailor that for your practice. Talking a little bit about random or routine urine testing, I mentioned routine. You should never do urine testing on a routine basis when a patient is low risk, has been stable on an opioid, and doesn't give you any reason to believe they're misusing it. When I mention routine testing, it's routine when a patient first enters your office to do a urine test to ensure that there's nothing in the urine that needs to be addressed prior to you initiating your particular modalities or prescriptions. So the purpose of this is to identify drug misuse. A patient may come in for a first visit, pre-prescription, and you've picked up something in the urine that shouldn't be there, perhaps an illicit substance that the patient has been using. That particular use and the behavior related to that use needs to be addressed. And you may initiate at that point CBT, or you might send them for addiction risk assessments or evaluation to see what's going on. So that's kind of routine testing. Random testing should be whenever you are prescribing to a patient, that patient then should be randomly tested to determine that the drug levels in the urine correlate with what you're prescribing, and to make sure that indeed the patient is using what you are prescribing and is not using possibly an illicit substance or a medication from another physician. So these are urine drug tests that help you do that. So as a follow-up from the urine drug testing, the other element that requires to be consulted in order to correlate your testing or compliance of the patient is the prescription monitoring program. The requirement as of now is that this database be consulted 24 hours prior to you writing a prescription within that 24-hour period. And that's for each prescription that you prescribe to the patient that's a controlled substance. Urine drug testing, I'm just going to go a little more in depth. Random is the rule of thumb versus scheduled. You never tell the patient when they're going to have the urine test. It's purely random. The patient doesn't know when the testing is going to be done. The frequency can vary based on your risk stratification of the patient and based on the previous urine screen that might tell you that something is going on that shouldn't go on, and you may want to monitor that patient more frequently. You have to know the laboratory you're testing. The ideal is to stay with the same laboratory so that your results are always based on the same processing system. When you do get these results, please evaluate for the presence of the metabolites. It's not enough to say that the parent drug was there. You need to know what variations and what proportions of the metabolites are present in the urine. Keep in mind that there's genetic variations in opioid metabolism that may affect the levels of metabolites in the urine. And you might have to take that into consideration in doing your interpretation. Usually the labs that you use are very astute, and if you need assistance in that, they have a toxicologist that's available with a phone call that can educate you and assist you in your interpretation of the data. Creatinine concentration is part of the urine testing, and it helps you to determine if this requires creatinine correction in determining the data. Likewise, specific gravity is very important, because we all know if you have a specific gravity of 1, that is water. And the patient may have tampered with the urine specimen, and so you need to know that. So interpretation of that data is extremely important. Doing the test doesn't necessarily protect you or mean anything without a proper interpretation. And confirmation testing may or may not be necessary. Such testing may involve actually determining blood levels if necessary. With this element of confirmation testing, there are 2 sections to urine drug testing. The point of care testing, which is essentially a cup in which you dip in a piece of indicator that will change color and tell you yes or no that that particular molecule is there. That is totally insufficient in itself without a confirmation testing that tells you exactly how much of each molecule is in the urine. The COM17 should be part of routine assessment prior to initiating opioids, as well as to assess ongoing treatment and screening. To this effect, if a patient comes back with a score from the COM17 testing that says they're at high risk, and you have initiated an opioid, you've done urine testing, and you've documented the patient appears to be following your protocol accurately, it may be useful to do this test again to demonstrate that the risk has lowered with you doing your appropriate monitoring. And this supports your management protocol and your treatment of the patient. The test in itself, the evaluation in itself, is used as a supplement to your physical exam, your interview, your clinical assessment, your risk stratification assessment, and it's used to basically, it's used in conjunction with those elements. Pain assessment during treatment. This is really important. I've mentioned that always reevaluate the patient. Every time you write a script, there has to be an evaluation as to the justification and continuation of that script. Confirm meaningful improvements in quality, pain, and function. The 4 A's are very important. Those are the elements which I'm referring to. Analgesia. How much pain relief are you getting? Activity. What are you able to do since I've placed you on this opioid that you could not do before? Then your evaluation of aberrant behavior. Whether you've called the patient back for a pill count, whether you've done a urine screen before, and what were the results of that urine screen. Does the patient use the prescription as you have prescribed? Those are elements that may tell you there's no aberrant behavior, and if the patient's not following your protocol or has something abnormal in the urine, that's a red flag to say there's aberrant issues going on that need to be addressed. And then what has to be also the 4th A is the adverse effect profile. You have a patient on an opioid, are they reporting any adverse effects? Now, in those adverse effects, it's important to document also that with the patient being on your opioid, they are not demonstrating on your evaluation any signs of toxicity, excessive sedation, or excessive side effects to the medications you're prescribing. And that's important because that helps you to continue to justify, based on some of the other criteria, continuation of that medication. If a dose increase is warranted, you can do that at that visit, and then again reevaluate the patient depending on how long you have given the patient that dose increase for, whether you've decided to increase the dose for a week or 2 weeks and reevaluate, or whether you gave them a 4-week script and bring them back for a reevaluation. And that's really based on your clinical judgment. But essentially, when you do an increase in dose, a reevaluation to justify that dose increase is definitely necessary. For continued therapy, you have to reassess benefits and harms, so it's always in a reevaluation of benefits versus harms every time you write the script. But if you don't do the script for 3 months, you've done something that you're able to give a refill on, then it has to be every 3 months. You also have to, while you're giving an opioid, optimize the non-opioid therapies and maybe continue them and adjust them as needed. And at your reevaluations, you're basically determining whether to continue, adjust, taper, or stop opioids. When you do prescribe opioids for non-cancer pain in terms of long-term opioid use, realistic expectations have to be set. Patients with chronic pain do not necessarily present to you like someone visually in acute pain. Acute pain, a patient may be bent over, may grimace when you palpate the area of acute pain. In a chronic pain patient, they may not present with those elements. So realistic goals have to be set. You have to tell patients you do have chronic pain. Your aim is to reduce the pain to the point where function has improved or where they feel comfortable. You're not aiming for zero pain. You have to verify what modalities they've been on, what treatments they've had that are non-opioid treatments before you decide you're going to give them an opioid. If a patient comes in and says they've never had physical therapy, maybe that's the first line of treatment before you prescribe an opioid. You also have to discuss risks and benefits with the patient, such as overdose and addiction. Evaluate risks of harm and misuse. Risk stratification is part of that. Consult the prescription monitoring database and do an initial urine screen before you've even prescribed anything for them. Have criteria in place for when you will discontinue or wean or stop an opioid. If certain elements are not met based on your criteria by you providing the patient a prescription for an opioid. Patients have to be assessed, baseline pain, function, and a reassessment or initial assessment is very important. And prescribe initially perhaps a short-acting opioid with the lowest effective dose before you prescribe a long-acting opioid. However, in patients who have chronic pain, more often than not, they've already been on short-acting opioids before you see them. It's important to realize that when patients are on opioids, whether they are short-acting or long-acting opioids, there are certain boxed warnings that are in the package inserts of every single opioid. There's always a risk of addiction, abuse, and misuse with any opioid, irrespective of how the preparation is made, that can lead to overdose and death. So risk assessments are extremely important. Monitoring the patients for aberrant and addictive behavior is extremely important. I've mentioned that. Life-threatening respiratory depression can occur with all opioids. Accidental ingestion can occur, especially in children, that can result in overdose of the child. Prolonged use in pregnancy can result in the neonatal opioid withdrawal syndrome, and recent data shows that that is on the rise. Combinations with other CNS depressants can result in respiratory depression and death, and that's part of FDA box warning. If the patient has inadequate pain relief, what are your treatment options? You may opt to increase the dose slightly, and the important element here is to minimize toxicity and some of those FDA box warnings in order for you to also find the lowest effective dose. Keep in mind that not all patients who complain of inadequate pain relief when they have previously been stable on a dose, not all of them will necessitate a dose increase. So an evaluation and a thorough evaluation of the patient as to why they are complaining of increased pain is important before determining that you're going to increase the dose of an opioid. One may opt to do an opioid switch or rotation to a different molecule that may perhaps work on a different receptor subtype. And that's certainly an option, and that can be done based on the equianalgesic dosing conversion tables. When looking at or using the equianalgesic dosing conversion charts, keep in mind that there's incomplete cross-tolerance between different molecules, and that may hinder some of your calculations and approach when you're trying to do that conversion. You may add a non-opioid agent in order to optimize the analgesic effects. However, I've already mentioned that a non-opioid or adjuvant therapy should be the first line before you initiate an opioid, but this is in the FDA data. You may opt to discontinue an opioid if the patient's experiencing such intolerable adverse events, or if they're non-adherent to your treatment protocol, or if they exhibit aberrant behavior. When looking at long-acting opioids, the advantages of long-acting opioids lie more with the ability to provide consistent plasma levels in a dosing regimen that is not frequent, i.e. not more than Q12 hours, with fewer daily doses being used. This may result in improvement in adherence to the treatment protocol. You may consider this in patients who have been using short-acting opioids for a long period of time, at least based on the guidance, less than 90 days. So the take-home message there is you do not want to keep a patient using short-acting opioids for longer than 90 days. So short-acting opioids should not exceed 90 days, and patients with chronic non-cancer pain should not be given more than one long-acting opioid at a time. And to that point, I want to mention that when lowering or trying to wean a patient from one long-acting opioid to make a switch to another long-acting opioid, you do not play the seesaw game where you lower the dose of one and initiate a dosing of the other long-acting opioid and reduce and increase as you go forth. The idea here is that you get them off one long-acting opioid, whether you use an equianalgesic dosing conversion chart or not, or whether you just plan on weaning down and initiating a new long-acting opioid. You always have one long-acting opioid in use at any particular time and not two. There are abuse-deterrent opioids in the market, and this has been based on the fact that there is a need for novel designs in the opioids that are available, and the FDA guidance that says we need to look into these kind of technologies. There are certain elements in the FDA guidance that have been put out for manufacturers and designers and researchers to use when looking at how to bring out these new molecules, or in some instances, some of the old molecules that we've used in short-acting formulations, but to bring them out as possible abuse-deterrent formulations. And the first element in the FDA guidance dictates that in vitro manipulation and extraction studies are required to see how easy it is to modify or manipulate these particular preparations in order to convert them into a form that's easy to abuse. And the data shows that the first way of abusing is crushing and snorting. And so manipulation studies are extremely important. In the pharmacokinetic studies, they are looking at the plasma levels when these particular medications have been manipulated. Looking at does the plasma level vary significantly when the drug is manipulated. In the third element, there's the clinical abuse potential studies, where in a controlled environment, drug users or misusers are brought in and are asked to take different forms of the preparation, intact versus manipulated, and are told to report back as to how high or how much liking they had for the various formulations that have been presented to them. The fourth element is essentially post-marketing. When we have the label that have met the first three criteria, how has then the use of that particular formulation, abuse deterrent or resistant, how has that resulted in data that we have from the community? How has that caused a reduction in overdose deaths, in misuse and abuse in the community? And that data only comes in when these formulations have been used in clinical practice. Data usually takes about 2 years to come out. There are various long-acting abuse-deterrent opioids, and without belaboring the point, each one of these that are listed in the table have different mechanisms that have allowed them to obtain a label that either states that they either have abuse deterrence or abuse resistance built into them. And I would suggest that you read the package insert, and if you're still unclear, contact the manufacturer to get further information as to how those molecules have been designed to result in a reduction of the ability to misuse or modify or manipulate that particular molecule. When one discontinues opioid therapy, you may want to discontinue it because of the unmanageable side effects or these side effects are severe. Perhaps the patient's non-adherent to your treatment plan or is exhibiting unsafe behaviors, or perhaps you've been able to pick up misuse and abuse and diversion, or perhaps the medications is not effective. And then you have to consider discontinuation of opioid therapy. So in terms of how you taper it, you decrease the patient dose based on their current dose that they're on. And you may decide to do a dose reduction that can vary between 10 to 50% of the initial dose that they're on. And you may be able to do that every week. Now, this is a guidance, so you have to take that based on how your office works and whether you can actually see the patient in a week. And so with each script that the patient comes to see you, that you issue, you do a further reduction based on the percentage that you've initiated with the first tapering. You do a slow tapering to minimize adverse and withdrawal effects, and that's really important. If the patient does exhibit severe withdrawal, you may want to treat that. You always individualize the tapering protocol to the patient that's sitting in front of you, based on your knowledge of the patient. Monitor the patient frequently during this tapering, and consider the addition, if you haven't already, of adjuvant agents. But most likely, these patients are already on adjuvant agents prior to being on an opioid, so you will just maintain those agents or perhaps taper the dose or modify the dose of those agents based on how the patient's doing during the weaning process. If counseling is required, because the patient sometimes may have mental behaviors that may be a result of the withdrawal, counseling with a counselor or a psychologist is definitely necessary to provide the necessary support to make tapering and weaning successful. You may experience mild opioid withdrawal syndromes that may last for 6 months. This is not really seen on all patients, but it can be seen in a very small number of patients. One just needs to be alerted for it. Most of those mild opioid withdrawal syndromes do not require treatment, but essentially reassurance of the patient that they will improve. Importantly, do not treat a withdrawal by putting the patient back on the dose that they're on, unless there's an absolute reason for that. And also, do not provide benzodiazepines as an option to treat withdrawal or as an alternative to an opioid. We will look at the guidelines for appropriate prescribing of opioids as currently produced by the CDC. These recommendations are essentially for primary care providers on creating a safe environment in terms of prescribing opioids. This is based on the fact that primary care providers account for 50% of all opioid prescriptions in the United States. And it doesn't provide a recommendation for treating pain relative to palliative, active cancer, and end-of-life care. So there are 12 recommendations grouped into 3 areas. You have to determine when to initiate or continue opioids for non-cancer pain. Your opioid selection is important in terms of dose, duration, follow-up, and discontinuation. And you have to assess risk and address harms of opioid use. When you initiate or continue opioids, the recommendation is non-pharmacologic and non-opioid treatments prior to opioids, and we've mentioned that in the previous slides. If you do initiate opioids, you will combine non-opioid modalities and medications as appropriate. Treatment goals have to be established, both from your point of view and from the patient's point of view. And if those patients' treatment goals are unrealistic, the patient should be told they're unrealistic, so that both of you are on the same playing field and we are starting off from a level playing field. You must monitor improvement in terms of function and pain, and also evaluate the risk. You should also weigh potential risks versus benefits and discuss this with the patient when you start opioids. Monitoring periodically is extremely important and mandatory. When you start an opioid, immediate release formulations are preferred, especially when the patient is opioid naive. Administer the lowest effective dose and titrate to the effect you're looking for and the dose that provides that effect. You monitor the improvement in pain and function and try to avoid exceeding 50 MME per day. Doses above 90 MME are generally not required and should be avoided, not necessarily excluded, because there are some patients that seem to function better greater than 90 milliequivalents per day. But make sure your documentation is solid to support using more than 90 milliequivalents per day. For acute pain, once again, prescribe the lowest effective dose. Do not prescribe longer than is necessary. 3 to 7 days is usually sufficient. However, if the patient needs it longer than 7 days, you need to evaluate the patient in order to justify that you are going to continue to prescribe it, and then you are able to give the prescription. When you initiate opioids, evaluate the patient within 1 to 4 weeks if the dose has not changed, and always evaluate the 4 A's, which include the analgesia, the risks, the side effects, and the aberrant behaviors. If patients utilize opioids for a longer duration than what you expect, that is beyond 3 months, you need to monitor these patients and consider switching to a long-acting opioid. Patient has to be screened for risk factors for opioid-related issues, such as overdose, before you initiate treatment, and do that periodically during the process of the therapy or the treatment. You should always evaluate the patient's substance abuse prescription history. So the prescription monitoring database is extremely important, and that has to be consulted prior to prescribing an opioid within that 24-hour prior to doing that prescription. If patients utilize opioids for chronic pain, urine drug tests are almost mandatory, and they should be done prior to initiating the opioid therapy, and then based on the risk stratification, at least 2 to 3 times a year, or in patients who have high risk, you may do it almost monthly or at every visit, and patients at low risk should have it at least a minimum of 2 to 3 times per year. Benzodiazepines, it is not recommended that benzos be prescribed or at least continued when prescribing an opioid. However, some patients are on benzodiazepines for psychiatric illnesses. It's extremely important to obtain the input of a psychiatrist to ensure that that benzodiazepine is justified when you prescribe an opioid. And if you do have to prescribe an opioid, please keep the dose at the very, very minimum dose, lowest possible dose, and evaluate those patients that they certainly do need the opioid, because the benefits of taking an opioid outweigh the risks of using the opioid concurrently with a benzodiazepine. If the patient develops an opioid use disorder, provide the patient with information to get treatment, perhaps do a referral for the patient, and there is a toll-free line that's available that patients can go to. If at any time an opioid use disorder is identified, it may be appropriate to reduce the opioid dose and or frequency, while at the same time addressing the opioid use disorder either yourself or with an appropriate referral to an outside source that can initiate an appropriate management for that disorder. So in summary, the slide deck that I've presented is designed to provide you with an education and knowledge base that will allow you to prescribe an opioid appropriately and in a safe fashion. And the key points and take-home messages that I wish you to go home with is that opioids are not always the first line of treatment when someone presents to you in pain. Second point, if you do decide to prescribe an opioid, that you perform a thorough evaluation and do a full risk assessment before you initiate the opioids. Third point, if you do have a patient on an opioid, that you consult the prescription monitoring program and that you continue to evaluate the patient for continuation of that prescription and continuation or reevaluation of risk as the patient continues to remain on the opioid. Fourth point, there's guidance on weaning. There is guidance on possibly using the least appropriate dose for the maximum benefit in the patient. And the final point, that these bullet points and slides that I've presented are all based on data and guidance from the CDC and have been adapted to take into consideration some clinical practice that will, in the end, assist you to be a responsible prescriber, will assist you in ensuring that your patients are responsible patients, and will also assist in the reduction of opioid misuse, abuse, and diversion in the community. With that, I'd like to thank you for your attention during this important slide presentation.
Hi, my name is Carl Fiebelkorn. I'm Senior Associate Dean at University of Buffalo School of Pharmacy and Pharmaceutical Sciences. As part of my responsibilities, I teach pharmacy law to pharmacy students, pharmacists, and many practitioners. And today I'm going to be talking about the laws, rules, and regulations concerning prescribing a controlled substance in New York State. Controlled substances, obviously, there's 5 different schedules, C1 through C5. You'll be only dealing with the latter 4. The laws and rules and regulations are found in the Federal Controlled Substance Act and the New York State Controlled Substance Act. This slide shows the different references that you can look if you so desire to go there. The purpose of issuing a prescription has to be issued by a practitioner for a legitimate medical purpose in good faith in the course of your professional practice only. That means your professional practice and training. Responsibility for the proper prescribing is upon you, but on our side as pharmacists, and I'm a pharmacist for 38 years, you have to have a bona fide DEA number and be registered to receive official New York State prescriptions and to register your software with the New York State Bureau of Narcotic Enforcement. We have a corresponding responsibility as pharmacists and liability to make sure everything is good with that prescription and the patient is a bona fide patient. We have to make a good faith effort to verify the identity of any person accepting the delivery of a prescription and to verify your identity if you're not familiar to us. The use of controlled substances, you use controlled substances in the treatment of your patients, not for addiction unless you're in a special program. You regulate the dosage, administer, and prescribe a quantity no greater than ordinary members of your profession for sufficient for proper treatment. So in other words, like other providers in your profession and what they would do normally. The PMP, or the Prescription Monitoring Program, you have a duty to consult this for anything that's in the C2, C3, or C4s, and it's optional for C5s, unless you have some type of an exception, and those exceptions are written in Section 8063, and we'll talk about that. You may check that up to 24 hours in advance for a variety of patients. You may see medical marijuana on the list. That just started with medical marijuana in New York State, I think it was last year. If you do not check the PMP, you have to document why not, and it must be an approved exception again, as stated in 8063. There's a nice FAQ document. I put the front of it on the side of the slide there, and there's the reference below that you can look up, and it's got about 140 FAQs in there to answer any questions. And online it's searchable, so you can search on any topic you want. Why does controlled substance prescription that I prescribed previously not show up on the PMP? Well, it could be a variety of reasons. The patient lost that script. The patient never filled it. Maybe it was too expensive. The patient filled it outside of New York State. Why can I not find a patient I know had a controlled substance script filled? Well, it depends on the format that's entered and depends on the format that you're looking at. So if a pharmacist on one end entered Pat and you're looking under Patricia, you might not find it. It could be a transmission error by the pharmacy itself. Maybe they misspelled your name when they put it in or accidentally put in a wrong digit on the DEA number. So if you're looking for something like that, since you e-prescribed it to the pharmacy and the pharmacy you know where it is, you could just call them up and contact them to make sure the patient got it filled. Nursing homes and hospitals have a little funny exception to this. If the patient is receiving a medication on the premises on site where the drug is consumed, you as the prescriber need not check that PMP. But you have to indicate that each time you order something in a hospital or nursing home. So you have to mark that in the chart that you didn't have to check the PMP. They came up with a nice little mnemonic NPIP as a shortcut, so you don't have to keep writing that all out, which means no PMP institutionalized patient. So not checking the PMP, you can just say NPIP. Where the patient consumes the medication off premises, you have a duty to consult the PMP. So if the patient goes home from a nursing home for a couple weeks for Christmas and you write another script for them to go off campus, then you have to check that PMP. A 7-day rule, which was passed last July, that 7-day rule states that you may not initially prescribe more than a 7-day supply of an opioid medication for any acute pain. This does not apply to any chronic pain such as cancer, hospice, end of life, and so on and so forth. But it's important to note that you can prescribe that 7-day, and if the patient needs more after that, you can give a bigger supply after that. So any subsequent consultations for the same pain, the practitioner may issue in accordance with existing rules and regulations any appropriate renewal, refill, or new prescription for an opioid. We're not required to verify any of this with you, so you can just do whatever you need to do for the patient and take care of them. You have to keep patient records according to Section 8062. Practitioner, you have to maintain a written patient record for any administration, if you were to dispense controlled substances, any of the prescribing a controlled substance, and yet it has to contain sufficient information to justify the diagnosis and warrant the treatment. It's got to contain at least the following: the patient ID, chief complaint, present illness, and any kind of physical exams or any kind of lab tests and things of that nature to verify that diagnosis. So other data to support it, the regimen including the amount, strength, and directions for use of the controlled substance. That way when you go back and take a look, you know exactly what you gave them. Types of prescriptions out there. Written prescriptions are not going away. That's a misconception. So there are still official New York State prescriptions out there. The exceptions to an official New York State prescription for a written prescription would be things like prescribers not practicing in New York State. So if you happen to be in the tri-state area and you're practicing in Pennsylvania, you don't have to worry about putting one on official New York State. Any clinics or hospitals on federal land, that would be VA hospitals, Indian reservations, or any kind of military bases like Fort Drum. We also have verbal prescriptions. Again, they're not going away either. There's going to be some instances where you're still going to have to call the pharmacy to order something, and of course electronic. And everything should be electronic, but there are exceptions to that. A rule of thumb, the same rules apply to electronic prescriptions as written prescriptions. So whatever is required on a written prescription is required on an electronic prescription. Same goes for faxes and verbal prescriptions. Same rules on faxes as verbal prescriptions. Fax to fax is allowed because it's telephonic, it's not electronic. A computer to fax, if your computer was going to fax to pharmacy, that's no longer allowed. Any faxing has to be on an official New York State, and it has to have your signature prior to you faxing. Public Health Law, Section 281, dictates that practitioners are mandated to electronically prescribe both controlled and non-controls effective March 27, 2016. However, there's a number of exceptions to that, where you could issue an official New York State prescription, a verbal prescription, or a fax prescription. And remember, a fax, again, has to be manually signed in an official New York State. And then you must indicate in the patient's health record when using one of those exceptions. And there's the references on the bottom, and I'll go over some of these real quick. Temporary technological failure, if your lights go out and your computer goes out. Temporary electrical failure, any kind of an approved waiver, if you apply to the B&E and they approve a waiver for you, where you reasonably determine that it would be impractical for the patient to obtain any kind of substances, controlled or non-controlled, prescribed by an electronic prescription in a timely manner, and such delay would adversely impact the patient's medical condition. So you might be stuck somewhere, don't have your laptop, and then you would have to call it in. And that quantity of that controlled substance may not exceed a 5-day supply in this instance. Anything to be dispensed by a pharmacy located out of the state, again, anything out of the state, Pennsylvania, Ohio, or any place like that, or including federal institutions, again, VA hospitals, Indian reservations, and any kind of military bases like Fort Drum or West Point. Commissioner of Health has blanket waivers that were effective until March 26, 2017, and these were just recently extended to March 25, 2018. This is under Public Health Law, Section 281-3. The following circumstances allow a practitioner to issue a written official New York State blank or an oral prescription for a controlled or non-controlled prescription. The practitioner is not required to indicate this circumstance on the written official New York State or the verbal prescription. These would be things like prescriptions with complicated directions, might be something like prednisone, prescriptions with directions longer than 140 characters, compounded prescriptions that contain 2 or more products in the compound itself, or compounded infusion prescriptions containing 2 or more products. A prescription containing certain elements required by the Federal Food, Drug, Cosmetic Act, something that needs an attachment, maybe you can't send that electronically. Approved protocols under expedited partner therapy. Approved protocols under collaborative drug management. Response to a public health emergency that would allow a non-patient specific prescription for something that people would be needed to be treated for. Any kind of research protocol or any kind of non-patient specific prescription for an opioid antagonist like naloxone. The blanket waivers, the commissioners decided the blanket waivers for nursing homes not be extended for the full year, but these will be extended until October 31st, 2017. And this is for those who've written official or New York State prescriptions or verbal prescriptions for controlled or non-controlled again. And these are to be communicated to a pharmacist serving as a vendor of pharmaceutical services by an agent who is a healthcare practitioner for patients in nursing homes and residential healthcare professions as defined by Public Health Law 2801, and a pharmacist serving as a vendor of pharmaceutical services who's receiving this and dispensing in the conformity with that, as stated above. That's what an official New York State looks like, and you already do that and you already see those type of things, but we just ask to make sure when you do this that they're filled out in its entirety if possible. It prevents any kind of medication errors. Again, official New York State prescriptions, the written types, they must contain the signature of the prescriber, and they're paper and they have a lot of security features on them. So let's talk about electronic prescribing in New York State itself. This became mandatory as of March 26 last year. Electronic prescriptions on a federal level, the federal states that electronic prescribing of controlled substance is optional. Not so in New York State. New York State is a mandatory state, and it's actually the first state to make electronic prescribing mandatory for both controlled and non-controlled substances. To sign a controlled substance prescription with your electronic software, that electronic program application must require the practitioner to authenticate it to the following three factors. Something that you know, and this would be a password or response to a challenge question. By the way, it's a felony to give out your password to somebody else in the office and have them use it. Something that you are, this could be a biometric data such as a fingerprint or an iris scan or something like that. Some pharmacies use actually fingerprints to fill their prescriptions with. Something that the practitioner has, a device like a hard token separate from the computer to which the practitioner is gaining access. So you have to use 2 out of 3 of those. Many people already do this. If you go to an ATM machine, your hard token is your card, and your password is your password, and you're using 2 out of 3. Electronic prescriptions created and recorded and transmitted by electronic means, and they're issued and validated by your electronic signature. They're electronically encrypted to prevent access or alteration and directly transmitted from you to the pharmacy itself. E-prescriptions are not email, not even if it's encrypted, faxing, texting, or any type of social media. They must include your prescriber's NPI number, your digital signature, whether you want the brand or generic, and an official New York State that you hand to the patient that says electronically signed by the prescriber is not considered electronic prescription. So electronic prescribing, there is also an FAQ document for this, and this is a very good document, has about 150 FAQs, and again, this is very searchable. Don't forget, electronic prescribings for controls and non-controls. It does not include any over-the-counter medications or any herbals. Everyone must have their system approved by the DEA, and then the software, you have to be registered with the Bureau of Narcotic Enforcement unless you're waived again. This is an electronic prescription that we see as pharmacists from our side, just to give you an idea of what you're transmitting. So when we look at this, on the top of it, the prescriber is Howard Wallowitz, and the patient's name was right underneath Sheldon Cooper. And the prescription is underneath that, and it shows basically what is sent to our side, and then we fill it and go on with that. Written or electronic prescriptions, all pertinent information must be included. Patient demographics, your information, the drug information, obviously. And New York State, if it's a written prescription, dictates it's 1 drug per blank. So no prescription for a drug written in New York State by a person authorized to issue the prescription shall be on a prescription form which authorizes dispensing or compounding of any other drug. That does not mean when you're sending these electronic prescriptions, they actually come through one at a time to us. So that's already set that way. There are exceptions to this. Again, Article 28 facilities like hospitals, nursing homes, and so on, developmental centers and developmental disability services in the Section 1317 mental health law, and more than 1 controlled substance may be written on an inpatient or medical order or a patient-specific prescription form in a residential healthcare facility. Some things that we see coming on our side from medical practices is sometimes the practitioner will choose the wrong patient, forget to shut down one patient's profile before prescribing for another, choosing the wrong drug or the wrong strength, using the wrong shortcuts. Maybe you invented your own shortcuts for spelling or the drug name or things like that. Letting office personnel use the electronic prescribing software. Turning off safety features off the system, so you might get a drug interaction that comes up all the time and you're tired of looking at it. Look-alikes, sound-alikes, drug names, choosing lab names instead of drug names, not keeping the data system up to date, fatigue with the system, seeing that same system, seeing the same alerts all over time and time again, and being interrupted while you're e-prescribing. Written official New York State blanks, your name must be imprinted or stamped legibly and conspicuously on the blank somewhere. The name of the prescriber who signed the prescription has to be on the blank. So if you're using a hospital or clinic blank, you've got to make sure you stamp your name next to your signature. Written or electronic prescriptions, all prescriptions for controlled substances must be filled within 30 days of the date the prescription was issued by you. No additional prescriptions or refills of those prescriptions by pharmacists may be issued by a practitioner to an ultimate user for the same controlled substance, unless or until that ultimate user has exhausted all but a 7-day supply. This is known as the 7-day rule. Written and electronic prescriptions for C2s and anabolic steroids. Anabolic steroids on the federal level are federal Schedule 3, and on a New York State level are New York State Schedule 2, which makes New York State stricter. There's a maximum of a 30-day supply, and there's no refills. Benzodiazepines are a Schedule 4, and again, its same rules apply to these, maximum 30-day supply and no refill. 3, 4s, and 5s that are not benzodiazepines, again, maximum 30-day supply, and you can put 5 refills within 6 months if you so indicate. The Federal Controlled Substance Act states that a prescriber may issue 3 prescriptions for the same controlled substance at the same time to a single patient. Again, New York State is stricter. New York State says no. New York State has what's called condition codes, and the condition or code must be indicated on the prescription if you want them to have more than a 30-day supply. So for the conditions for controlled substances in New York State, you can prescribe up to a 3-month supply as determined by the directions for use. So in these indications, you can prescribe more than a 30-day supply, up to a 3-month supply for these different conditions: panic disorders, attention deficit hyperactivity disorder, chronic debilitating neurological conditions characterized by movement disorder or exhibiting seizure, convulsion, or spasm, relief of pain in patients suffering from diseases noted to be chronic and or incurable. That relief of pain doesn't have to be cancer pain. It can be other types of pain that you decide what they need. Narcolepsy, and then anabolic steroids has their own code also. And anabolic steroids are used for a variety of conditions, and you can prescribe up to a 6-month supply of those. The New York State condition codes for controlled substances for C2s, anabolic steroids, and benzodiazepines, again, no refills. But for 3, 4s, and 5s, if you want to, you could put a refill on there. So you could give a 3-month supply with 1 refill. Verbal and faxed, C2, anabolic steroids, and benzodiazepines, again, you must send that follow-up within 72 hours with an official New York State or electronic. Probably it's going to be much easier just to send an electronic prescription. The follow-up must state authorization for emergency dispensing, and otherwise, if we do not receive that, the pharmacists are required to report to the Bureau of Narcotic Enforcement and the DEA if we don't receive a cover. 3, 4s, and 5s, again, you must send it within 72 hours via a written official New York State or electronic. Persons authorized to issue verbal prescriptions. Well, again, you might read where the federal law allows prescriptions to be communicated to a pharmacist by an employee or an agent of yours. Again, New York State stricter. Only you may prescribe verbally controlled substance to a pharmacist in any venue: the hospital, nursing homes, community pharmacy. We are required, as of last October, as pharmacists, to hand out information to the patient. And this is brought about by the Department of Health to talk about dangers of misuse and potential for addiction, physical warning signs, available alcohol and drug addiction treatment resources, proper disposal guidelines. And this information has to be included in the 10 most commonly spoken languages other than English in New York State. But it may be provided electronically if the patient requests. Contact information or questions, the Bureau of Narcotic Enforcement asked me to put down their website, and there it is, and they'd be happy to contact you with any answers to your questions. Thank you and have a good day.